start to think about having a knee replacement when your function starts to suffer. And for some patients, they need to be almost in a wheelchair because of the pain before they'll consider having that procedure. And then they have the procedure and they say to themselves, why did I wait so long? You'll know that you need a knee replacement usually because of an x-ray. You go in, you see that x-ray, the joint is all mangled and rough, and joints are supposed to be smooth, okay? And if you look at the actual bone itself, the bone is smooth, it's slippery, that all goes away. And that's why we need to have a knee replacement in the first place, because instead of that kind of nice smooth, you know, when you move your knuckles together this way versus moving them the other way. And that's the difference between a nice joint and an arthritic joint. Okay, and that's the best way I have to describe it to the patients. My knee pops all the time. That doesn't mean you have to have surgery. Or, you know, I get some swelling in my knee every once in a while. Those aren't necessarily precursors to you needing surgery. What happens is when all those things start to happen together. I can't squat down anymore because it's too painful. Or every time I walk a flight of stairs, my knee gets so big that I need to put ice on it. Or I can't walk a certain distance because I have so much pain in my knee that I just can't go any further. I would say before you get to that point, you know, when you're kind of halfway there, it's time to start asking your primary physician, hey, I've been having a lot more pain in my knee, or I'm noticing I can't do as much, or I'm more uncomfortable doing what I used to do. They're automatically going to take that x-ray, and that x-ray is going to let them know if you need a referral on to an orthopedic surgeon, if it's something that maybe we want to do some therapy, we want to intervene before we have the surgery. It certainly does not harm anybody to do some strengthening work before they have the surgery. The stronger you are going in, the better you are coming out. But those are the kinds of things that I would start to look for: pain and what we call crepitus, or that popping in the joint, whether or not you can hear it, you can feel it. Lots of swelling and just really not being able to do what you used to do. The joint has a structure that supports it, okay, the joint capsule, and it's like a balloon. So the more swelling that's in that knee, the tighter the balloon gets. Once that balloon gets too tight, you have a significant limit in how much you can move your knee. Okay, when that happens, you don't move your knee because it hurts, it's uncomfortable, so you keep it still. Keeping it still only creates kind of this vicious cycle of now it doesn't move, so I can have scar tissue start to set up. Anytime you put a joint, and as you get older, as we all do, you know, you put your body in a certain position and then you start to move out of that position and everything's like, oh, wait a minute, that doesn't feel so good. And that's also what's happening in a fresh knee joint, especially immediately following surgery. Those structures are not happy that they've been disturbed. They like to be where they are, they don't want to be cut, and that has all happened. And so the body's natural system says, I'm going to limit how much motion I want this knee to have, and so I'm going to send this swelling in. When you get blood added into the mix, the blood will actually destroy the cartilage and the surrounding tissues. Blood is blood. You don't want blood anywhere else than in your veins and in your arteries. Fibrosis is another way to look at scar tissue. It's scar tissue plus. Okay, some of the scar tissue that we have, you can kind of think of like spider webs, right? And so we can move the knee joint a little bit, or the shoulder, or whatever joint it happens to be, and we can break those spider webs, and we can get some range of motion back. Fibrosis is more like duct taping the joint. Okay, so now you have a good amount of scar tissue that has set up in that. And so when that happens, also the components that make up something that's fibrotic versus something that's strict scar tissue they're a little bit more intense. They're stronger, their tensile strength is stronger, they're thicker. So fibrosis compared to kind of what I would consider normal scar tissue is just really kind of scar tissue on steroids. And it's a lot harder to break through. Usually those are the people that need the manipulations because they've had that fibrotic tissue start to set in. The less I move, the sooner it happens. If genetically I'm prone to scarring, the sooner it happens, the bigger it happens. You know, you can look at how you scar when you cut your finger and how your body responds to that is a pretty good clue of what's going to happen on the inside. We've seen people that have those really big, bumpy, kind of gnarly looking scars. Those patients are more likely to have that same kind of body response on the inside. And so the when of the fibrosis depends on genetics. It depends on how long you want to sit still for. It depends on things like, I had a knee replacement and then I had an infection and then I had another knee replacement. And so if you have all of these other things that come with it that limit your ability to move that joint, you're gonna get that fibrosis a lot faster. I think X10 helps prevent scar tissue in general, right? If we can prevent general scar tissue, we certainly can prevent scar tissue on steroids when you talk about something like a fibrosis, because you get in and you get moving early. So I can hold in a position for 3 seconds, I can hold him in the position for longer than that. And so with a fibrotic joint, I just need to hold longer. And so I can still do those things if a joint's fibrotic and maybe not have to worry about a manipulation. The difference with the X10 is the patient's involvement. They're sitting, so that's better for their lung capacity actually, and their lungs and breathing and not having to worry about patients lying down and pneumonia and the things that kind of go along with, post-surgical concerns. The patient's leg is moving, so we're working on swelling, we're working on scar tissue, we're working on preventing DVTs. The screen that the patients see, and for most of our patients, it becomes a little competition with themselves. So now they're actively involved and it's less cheerleading that we need to do, which is great because the patients are much more compliant in what they're doing. It's always a big frustration with therapists in getting patients to be and stay compliant with their home program and doing those kinds of things. And we've had phenomenal success with the X10 and patient compliance. And so when they have all those pieces built together, the ability to kind of compete with themselves, and it especially works with the older gentlemen better than the ladies because it's just that competitive side that they have, right? They see that, oh, I got a degree more. Well, let me see, can I get another degree? Can I get another degree? And so what we're seeing is instead of patients coming out of home health at 90 degrees of knee bending and being able to get their leg all the way straighter, and sometimes even a lag. We're seeing patients now who have achieved full extension or full straightening of their leg. They're getting knee bending measurements 100 degrees, 110 degrees, 115 degrees. So we're really seeing great results with that, which moves them into the ability to walk easier, more normally than they were before. The majority of the patients go to outpatient therapy without a device. No cane, no crutches, no walker, none of that kind of stuff. And the sooner patients can get rid of that, especially the ones who weren't using it before, the happier they are, the more normal life becomes. And so it's a lot easier to progress patients and to keep the compliance when you have something that's more interactive. Not to mention we can put it in front of their TVs and that helps them pass the time as well. But in getting that knee motion faster, which we can do with the X10, getting the swelling out faster, which we can do with the X10, on top of the more frequent therapy, what we're seeing is significantly shortening what that painful window is. And by shortening the pain window and shortening the recovery window, patients are more willing to get involved in things like doing a total knee replacement, which they need in order to function better. The fear is if I get this done and I can't function better, what happens? And now we have a better guarantee, if you will, or we can promise them at least a little bit that, hey, this course of treatment is going to be shorter and less painful than it would have been before we had technology like the X10.